there, it's Wong with Hand Therapy Secrets, and welcome to my show. I am here every week to showcase to you a story of therapists that are breaking into hand therapy and making waves, and also to share with you other specialties that can really help support us in hand therapy world, and even tips that you can use and skills that you can use right away. So today what I want to share with you is my friend Aaron. He is a physical therapist in Jacksonville, and he specializes in functional manual therapy treatments, and he's going to share with you some great things you can start doing right away with shoulder types of injuries, and share his story how he works very collaboratively with other occupational therapists in his area. Enjoy the show. Hey Aaron, so wonderful to have you on the Huang Show. I still don't have a full title for my quote-unquote show, but this show is all about connecting occupational therapists or physical therapists who want to specialize in hand and upper extremity to other therapists to learn different techniques. And I'm really excited to talk to you today because you are specialized in something very specific, and I want to let other OTs and PTs know about it. So tell us a little bit about you and what you do, where you work.
Hey, well, thanks for having me on. Again, my name is Aaron Robles. I have a clinic here. I'm a physical therapist, and in Jacksonville, Florida, and I actually got 3 locations now. So what I am, I'm certified manual therapist in functional mobilization through the Institute of Physical Art. And what we do is take the principles of PNF and develop a dynamic treatment and evaluation approach with using those principles for manual therapy to get hands-on, to get to the root of the problem faster. So for me, it really fit my brain and my hands well, and it's really made me successful in trying to get to the root of the problem, not just the diagnosis when patients come in.
And how long have you been specialized, should I say?
Well, I was, I've been a therapist for over 25 years now, and probably in 24 and a half of those, I was training to be where I am now.
Oh, wow. That's awesome.
In PT school, I had the direction of, I knew I was good with my hands because all my classmates were asking me to help them. I was like,
okay,
well, wait a second. I don't know anything more than you guys. We're classmates. And they're like, no, we can't do what you can do. We can't feel that. So I sought out what kind of training I could do that really fit my hands and my brains.
Okay. So that's such a great, important point. So you knew that you were good with something.
Right.
And then you picked something where you could enhance that.
Right, exactly.
Am I hearing you? Okay. Yeah, because I think that's important for people to hear, because sometimes people want to be good at everything. But sometimes when you do too much, you in a way water it down. But you specifically knew you were really good with hands-on type of stuff, techniques, and so you sought that out. Did you find a mentor, or did you start taking classes?
Yeah, it started with a PT. We had an adjunct PT instructor at my PT school. She was Maitland-based, a lot of joint mobilizations. So she took me and another therapist under her wing and showed us how to do those kind of things.
Okay.
From there, then I knew, I was like, all right, this is how I want to do.
That's what you liked. Well, I'm really excited to have you show us some of the things that you do in your clinic. How did you get connected to occupational therapists in your area?
Well, actually it ended up being a patient of mine, and now it's a patient/friend. We got really close there.
Aren't OTs the best people to be friends with, Aaron?
They're just so social.
We're so much more fun, right? I try to tell all the PTs that I meet. I'm kidding.
So we started, she came to me for neck issues.
Yes.
And she had a long history of shoulder issues, but she's like, when she first came in, she said, just don't touch my shoulder. And, of course, I'm like, if you have an issue, let me see it.
How can I get to the root cause of your problem?
Exactly. I had to gain her trust, but then through that, she's like, because she's had bad experiences in the past with other therapists, PT and
We
OT.
all.
She didn't want to have anybody touch it. As a therapist, she knew, and she's like, you got to prove it to me. And she's like, after the first visit, she's like, all right, can you check my shoulder out? And from there, she just was like a sponge. She was like, okay, what are you doing there? How do you do that kind of thing? And she incorporated a lot of the principles, and because she could have empathy now for her patients, like, wow, this is going to hurt, but this can help you feel better.
Yes. Let me ask you, how difficult is it to treat another therapist?
For myself, it's the hardest part is just, I have to tell them often. I said, okay, let me be the therapist, because they'll tell me, okay, it's bothering me right here. It's this, it's this, straightforward, and it's not extending, and it's not letting me. Let me to see what's happening.
Yes. That working with other therapists is so hard.
Yeah,
it's so hard. But you also, because I've worked with other therapists, whether they're OTs or PTs or speech therapists. They have a tendency to maybe come in a certain way, right? But let me ask you, do you also have a tendency to think of them in a certain way?
When therapists come in?
Yes, because we can't help but make assumptions sometimes, right? Well, you're a therapist. You make assumptions that they know certain things, wouldn't you say?
Yeah. Well, there's things like I learn what to assume, right?
Right. We're not supposed to assume. We're not supposed to assume, but let's be honest, we're human beings.
I went through. So the good news is I treat everyone, because I have a lot of doctors in town as well as patients, and I treat
those
them.
Those are worse too. No, I'm kidding.
They are terrible because they can't get in. They can't get in. You only have one shot at them typically. But once once you combine them, like what I find, once you get past they think they have insight, but once I find things on them, like, well, I didn't even know that bothered me. I didn't know that hurt. I didn't know that was an issue. So once I get into the treatment wise, then they're like a regular patient. So that doesn't take long to transform that. So they change their mindset as well.
It's that first visit.
Exactly.
Very cool. So yes, the OT became your friend. She was your patient. She became your friend.
Exactly. So she's like, so she was really able to really expand her treatment when she's just took a lot of principles that she learned from me, just from our treatments. Yes. So, and then if they go advanced, she's like, oh, you got to go see Erin. So she'll transfer her patients over to me to get over all the hard things. And then we'll take it from there. So she has a new grad OT that I was just kind of shadowing her over the last month, and he's like, how do you know how to do all these things? She's like, well, let me tell you who. And then she's like, can we set this up where I could show, see how he does things? And we're brainstorming how to do it. And she was thinking, well, can you do a treatment on me and have him observe? And that's how it started. Well, it started from that to, well, we told a couple other OTs in our work, and soon it was like 2 more, 3 more, and ended up being.
Before you knew it, you had a workshop or class. Therapist.
Yeah. And it was a great hit. It was very successful. I started with giving them some kind of basics with just manual therapy.
Okay.
And some things I'd like to share with you guys today.
Yes, so please. So that the therapists that are watching, believe it or not, it's so funny, but obviously I do speak to majority occupational therapists, occupational therapist assistants and stuff like that. But there's a lot of PTs a small portion of PTs that do reach out to me because they want to specialize in hand therapy too. And then, within our own, my network of PTs that I know, they've sometimes when there's like little issues with like hand stuff, they've reached out to me too. So I think it's a great space to share knowledge and techniques.
True.
So show us who's your model there. Woohoo!
This is Mark.
Hey, Mark.
Here, so I recruited him to help us out. And Haley's our camera woman behind the scenes here. She'll be moving us around.
Haley, that's my daughter's name. I love that name. All right,
So,
steady, Haley. That's how I talk to my daughter. I turn on her stern voice. Steady. It's steady now, Haley. I'm kidding.
Well, let me start with give you a couple principles here with manual therapy. So the first one is, like I alluded to, I naturally had the skill, which I didn't even know I had until, it was compared to my other classmates. So that's when I sought it out further. So first thing everybody has to know, you have to understand that it is a skill, but it is a skill that needs to be worked on and can be improved upon. So even if you don't have the natural propensity to feel it at first, you have to first understand that you can, and it is possible to do so. And once you do it, then you could actually work on it and feel it. So number one thing, manual therapy, here's the first principle, is what you're doing with is end feel. So if you could think end feel, that's why I tell if I have PT students that come in town or in the classes I teach, if I ask you a question, if you answer end feel, you're going to be 99% right. So this is what we're going to talk about is end feel. Because you can't really feel what's wrong. I mean, know what's wrong to really feel it, in my opinion.
Yes.
So every joint in the body, no matter where it is, whether it's mechanical and to joint-wise, articular surfaces, or soft tissue mechanical issues, you should have a springy end feel. So that's what you want to make sure that all things, if you have no clue what's going on, especially with the wrist, with all the things going on in there, if you just poke around and you think, right, that is springy, and that's hard, there's a dysfunction. And that's where you start. You don't even have to know what's going on with it. You don't have
wait a second, Aaron. Some directions, there's going to be a hard end feel, though. It's majority springy, but some are hard end feels, wouldn't you say?
No, I beg to differ. All the joints, even in the elbow, this is where the elbow is a true hinge joint. It is springy. If the joint is moving in an efficient state, even though this is going to be a bone-on-bone articulation, it'll still be springy at the end feel if it's moving efficiently.
Okay, perfect. Oh, you see how I like that. I like to challenge you.
Okay, that's
I
good.
think Mark liked it too. Mark was like, "Oh, here he goes."
Mark can answer these. He should be able to answer all these things. So now, the main thing, now I'm going to teach you guys something else. This is basically the three principles of all therapists, actually. So occupational and physical therapy. If you guys know this, you will know more than 99% of other therapists out there. We treat the three things in our professions, okay? We treat mechanical dysfunctions, we treat neuromuscular dysfunctions, and motor control dysfunctions, okay? If you understand, we do those three that, give you a concept that's how you get a person to the root of the problem, get the person better, faster as well. Because mechanical is any kind of movement that is limited or just deficient.
Right.
Neuromuscular is whether you have a strength or flexibility issue and or endurance issue that you want to get to. Right. And the motor control is, can you move it when you need it?
Right.
So I often give the example of having a soccer team. So if you could think of it this way, so to know the differences, like a soccer team requires 11 people per team, right?
Right.
So mechanical issues like 2 of your players got lost on the way to the field, and so now you're 9 on 11. Can you function? Yes. Can you function well? No, you're hampered because you don't have everything there. You don't have all your facilities. So the neuromuscular end is you have all 11 on the field. They all made it there, but they all stink. They have no dribbling skills. They can't shoot. They have no strength, and they really have no endurance. They
can barely run across the field.
So when you get to motor control issues, you have 11 players on the field. They're all excellent skilled. They can go through every drill, every possibility. They have all the strength. They can run all day long. The only problem is they don't know their positions. You have the goalkeeper running down after the ball on the other side of the field, and nobody's protecting the goal, and nobody knows how to play defense or offense. And that's where we have to incorporate those three principles, and that's our pillars of our treatments. And if we understand that, we can get to the root of the problem so much faster.
Yeah, I love your analogy.
Okay.
I love it.
Good.
That's awesome.
Okay, so what I'm going to use Mark for. So one of the main things for manual therapy, so once you get to understand this and feel, is it's important with the tactile cueing that you give patients. So if you've taken NDT or any PNF, you'll understand some of this stuff, what we're going to show you, okay? So with Mark, I'm going to raise it up a little bit. Okay, so if you can see here, Mark is right-handed. Yeah. Okay, even though he's my example, he doesn't know what I'm doing and tell what to do. Okay, so he's a little bit higher. Okay, so you can see this. So what I'm going to do is, Mark, I want you to hold your hand there. I'm going to try to pull down. Any problems with your shoulder issues?
No.
Any excuses you're going to have? Okay,
I
good.
don't think so.
All right, so now I'm going to have him hold here. So this is one of my pre-post tests. I always pre and post test my patients. One of the things I want to show you is this. Hold it there. Don't let me pull you down. And come on, Mark, are you serious? Is that all you got? Everybody's watching. That's pretty sad. He's not a good example, or he is a really good example. Okay, now I'm going to show you the principle, which is unintended. We'll see if it happens. Look up with your hand, put your weight into your left foot, push down, and look up with your hand. Now don't let me pull you down. And now he's a lot stronger. Okay, that was an unintended PNF principle I wanted to show you, but it's about the pattern. Now don't look at your hand, Mark. Okay, now hold it there, and he can't do it. He has nothing. So he's missing, unless he consciously engages his core to help protect him, he can't hold his shoulder up there. That's not what I was trying to teach you today. Let me show you something else. Hold it up, look at it there, hold it there, don't let it way down. So he has it. Don't change a thing. Keep looking out there. Now, what I'm going to do is different. Hold it there, don't let it way down, and again, he's weak. But he's looking at your hand this time. Hold it there. He's now looking at your hand. So what was the difference? I don't know if you can see it. A little bit higher.
I don't know if I can see it.
Can you see my hand here? So I'm giving a whole circumferential tactile sense to him, and he can't hold it. But if I just put my surface on,
okay. Then he was able to.
I'll hold it there. He has it down. So it's very important, our tactile sense. So we want to make sure, if we're trying to find weakness in a patient, that it's actually in the patient and not us.
Not in our, yes.
Does that make sense?
Yeah.
So another thing here is this. So if we're testing the shoulder muscles, and he's just weak here, we want to isolate the shoulder muscle groups that actually is his weakness. Okay, hold it there, Mark, don't let me push down. Again, my tactile sense is here. If I push my down, he's strong. If I just wrap my fingers down, push down, and he's a lot weaker.
Yeah.
So make sure we're pushing the intended motion. Even if I say, push down, Mark, and I push down, even my tactile and verbal sense, verbal cues are contradicting each other. He's going to go with my tactile sense.
Yes.
So now, if I say hold it there, he's strong. If I put my hand on his deltoid, which is holding there, and test him again, he stays the same. It really doesn't change.
Right.
Now if I put my hand on his scapular stabilizers, okay, which is here in the back, now hold it there, Mark, and now he's weak, okay? So what happened? What does that mean, okay? So when I put my hand on a muscle group here, he's in the deltoids, he's strong. If I put on the scapula, he's weak. So it may seem that it's the scapular stabilizers, not the deltoids. But if I put my hand on a muscle, we're adding another tactile sensation to that to help enhance that contraction. So if I'm putting my hands on his deltoids and he can hold it, this is his weakness. Okay? If I'm putting it on his scapula and pushing down, and it doesn't make a difference, then it's not a scapula. And that's the basic of K-tape. If you know all the K-tape, K-tape, it's that to add that tactile cueing to initiate that muscle. So this is what we're doing with the hands. So you can initiate that as well to figure out where is his weakness into where it is, by putting your hand on there. If they're stronger with your hand on there, that is the muscle that you have to target for strengthening. Does that make sense?
Yeah, no, absolutely.
That's the first, primary principle. So now with Enfield, no matter whether it's soft tissue or whether it's a joint, it has to be springy. So if it's a
Yeah.
springy Enfield, then it moves like it's supposed to. If it's not, like here, this is hamate. So that's right now is not springy. Can you feel that?
Yeah.
And it's in an extension. You could also
Yeah.
do an inflection. And that's what you want to do. Feel
Yeah.
the infield. So if you can feel the infield, and you have to understand, if you don't have ideas of what that means, is find, and you have to practice that. Every joint, when you go to the end, it should just bounce back, just like
Yeah.
if you were down on a soft surface. It should be bouncy. You shouldn't be like on my desk and pushing
Yeah,
hard.
where it's hard. Do you recommend for people to kind of feel on themselves or feel on a normal joint so that they can get an idea of what that springiness or that
Right,
normal
exactly.
sensation feels like? That's normally what I do, is just, test on yourself, like see how your joints move, or like even your wrist, you should feel it a certain way, or you can test on someone else who quote unquote doesn't have a problem, right?
Right.
That way you can learn what normal feels like, so that you can know what abnormal feels like.
That's the best point in terms of manual therapy. So
Yeah.
how do you know how many dysfunctions there are? You can't memorize them all, but if you know what it's supposed to feel like,
Yes.
and you know it's not there, then
Right.
there's something wrong.
You know something is wrong, even if you don't know how to fix it. Like, that's something wrong there. Your hand ain't supposed to move, Mark. I think you got wrist problems.
So this is something that, to follow up with what you're saying, you could feel with soft tissue on yourself.
Yes.
So when you push, like if I push to a certain area and I engage my soft tissue myofascial, I should be springy. But you could even see it's hard. I don't know if I could see that, but you could see that I have a little mole here. If I push this way, the mole moves away from me. If I push this way, the mole goes closer to my finger.
Yeah.
A hard Enfield. So that's what you're feeling for in the soft tissue.
Yeah. Do you have people look around too? Because we work with a lot of people, and then it's not just where you're pushing, but like around, because it's supposed to move, and there's a certain amount of tension that's supposed to move everywhere. And when you can see when you're pushing in different directions, like certain spots, if there's a dysfunction, it just doesn't move.
Right, exactly. And that's the hard Enfield. And that's what you're doing. That's what you're feeling. So all those myofascial soft tissue should be free flowing. And that's how you isolate the D motion. If it's moving in this direction distally, that's what's dysfunctional. And then you could isolate even further. Is it more distally to the left or to the right?
Yes.
The hardest Enfield is the hardest in the most restricted area, and that's what you want to hit first. So now the next principle I want to show you, which is this foundational for the shoulder complex and the shoulder joint. The most important motion that you have to engage with the shoulder to get the full mechanical issue, because you guys understand the shoulder is the most mobile joint in the body. Obviously, it's going to be the most complicated part because of that, especially through pain in it, is inferior glides. If you could get that articular surface to inferior glide, and that's the first thing I have yet over 25 years to have a patient have any kind of pain or upper quarter dysfunction and not have this issue. So if you could get this issue down, they'll, not only impingement, but every other motion in terms of the carpal tunnel syndromes this affects. Okay? So let me show you how to do this. Okay? So
Cool.
This right here, this chair. Put your arm on your shoulder. Can you come a little bit closer now? So, right there. So now, what I try to do is get the table up.
Oh, you so fancy. Look at you with your
Table up here in this motion. Body mechanics. It's all about body mechanics.
I tell you.
So now, what I want to do is take his glenohumeral joint and just glide it in and feel his end. If I push straight down, again, I want to get to his end range, so that's it, and then spring it. And once it should be springy. it's not really springy. It's kind of hard, but not too bad.
Mark, what's wrong with you, man? Is Aaron making you work so hard that your body? I'm kidding. Yeah.
So one of the post-test I like to do to see if I'm effective here or not is do a passive abduction with their palm down. So relax for me, Mark. Let me do it for you. So if I bring him up, I'm going to feel where the first tension he gets, and it's right about there. So he's about 110, 115, where he's getting tension. I mean, I could through it.
You could, but you can feel the restriction.
Right. I want to feel the first tension is right there. It's first restriction.
Yeah.
If I put through it, but he's only there. He's only about 125, 130.
Yeah.
At the most, and he's
Yeah.
That's my pre-test. Obviously I do active and then show them the difference between active and passive because they get circumduct and move around that dysfunction, which you don't know. So if I push down, so obviously he has a shoulder glenular dysfunction. I push straight down, it's kind of hard. I give it, a medium dysfunction there. But if I push more anteriorly, it's hard. It's much harder. He doesn't move nothing. I don't know if you can see it. And if I push him posteriorly, he has bounce. You can even see it in his body.
So if you take a look at his shoulder, right? It's like I always describe that as a clock. So if you're pushing straight down versus like you're pushing a little bit more you're pushing downward, but instead of it being like 6 o'clock, you're pushing a little bit more 5 o'clock.
Right, exactly.
And then you're pushing posterior, you're pushing 7 or 8 o'clock.
Correct.
So I mean, just as a description for everyone who's watching that might not be able to.
You're exactly right. And that's what I'm doing. First assessing 12 to 6 if I'm looking straight at the clock in this motion here.
Yeah.
He has a moderate, you can see it. If I push straight down, he has a moderate restriction here. If I push straight down toward, starting at 12, now I'm going toward 7 o'clock.
7. Mm-hmm.
So it's an inferior glide with a posterior bias. He is much springier. So, you can actually see his body spring.
Yeah. Mm-hmm.
But if I go now toward 5 o'clock from 12,
right.
Again, the inferior glide with the anterior bias, he is hard. That's it. It's solid. He does nothing.
Yeah.
So the good news is that's easy to find. And the bad news is, this is on every patient you're going to have. They're going to have this issue. Otherwise, they wouldn't be seen. Okay, so now.
Yeah.
The simple treatment with this is I'm going to push them down to that end range, okay? I'm going to have them there, and then I'm just going to hold that end range, okay? And I'm just going to hold it there. Sometimes that's all you need, just a prolonged hold, and the joint will go. So the principles that we adhere to is we hold it, and if it doesn't move, then we do add some either indirect or direct mobility to get it moving. So direct mobility, I just kind of oscillate into that joint. You can do this with every joint in the body, just oscillate to see if it helps move. Okay? If it's too painful, then you have him do something more indirectly. I could hold it there and say, Mark, take a deep breath for me. As he's taking a deep breath, he's actually mobilizing his I
love deep breathing.
They're doing that. They're just thinking, oh, I'm holding my breath, kind of thing there. Okay, I could have them also just do an external rotation. Lift your hand up and down off the table for me. You have a little bit of motion. And what I'm feeling for it is that hard end feel improving, and it is. Now it's improving. Now, that's good. So that's more of an indirect pressure. I go back and reassess, and he actually has some motion now. Can you feel the difference, Mark?
Yeah.
He actually is moving better, and that's all I did. What was that? 30 seconds worth of treatment, and he's got a better inferior glide. So this is something that you could take straight down right now in all your patients and assess it and have them feel better already. So now what I want to do is see how much motion he has, and that is a lot better in terms of just in general big motion. So I want to retrain that motion because every time you get a new range, we want to train that range or else they'll lose it again. So I asked Mark, hold it. I'm going to push him down to that new range, anterior toward 5 o'clock, and say, hold it there, Mark. I'm going to switch my hands and don't let me pull you up. So now he's going to do a little shaking. I don't know if you can see him, but he's a little shaky because he hasn't activated these muscles in a long time.
Right.
I'm just pulling straight up. What I'm doing is just taking my hands and just pulling up. Careful, brachial plexus under here. Pull down, and put him back down. Hold it there again, Mark. Don't let me lift you up. again, prolong holds, and the best way to initiate and to engage muscles is in prolonged holds, especially if they haven't gotten a while. And then have them do some concentric eccentric, work. Let me pull you up slowly, eccentric work, now pull back down. Let me pull you up an inch more and pull back down. Now pull a bunch ins more and pull back down. Now let me pull you all the way up and pull all the way down. Pull all the way up and all the way down. Very good. Now he has that motion. Because with impingement, it has to have that inferior glides. Inferior glides,
so it doesn't.
What we're establishing. Now you have to establish his reconnection to his brain, to his shoulder, to get those muscles to automatically do that. So with that treatment, I'm going to reassess his passive range. Let me move you, please. Okay, relaxed. Until I feel tension. And now it's right here until I feel tension. So it's a lot better. He started at probably 110, 115. Now he's probably about 140 or so. Still hard and feel here, so he needs a little bit more work. But that is not much here already for his shoulder. And that didn't take long to do, as long as we know what we're targeting. So what my homework for him is, now, because of his shoulder impingement issues, Mark, I want you to think about when you lift your shoulder up, you're supposed to automatically do this to raise it up. You're not doing that. So anytime you're going to raise up, I want you to think about dropping your shoulder and then keep going up further. That makes sense? So do abduction for me. When you get about 110 there, drop your shoulder there and keep going. Very good. That's something he has to think about to do first, and then until it's automatic and he can actually do it without that.
Oh, very nice.
I appreciate it. Thank you.
Very awesome. Well, I really appreciate you taking all that time
to
show all of Mark's dysfunction.
For the world to see.
He's like, no problem. I got a free treatment. I'm good to go for another 2 days. No, I'm kidding. No, that's awesome. I really appreciate you sharing a lot of what you know. It's funny because sometimes when we've been doing it for a while, we have our version of saying it, or maybe we do certain things and we don't know why we're doing it. And I think that a lot of what you spoke about today was a great way for people to really remember and think about that. Because sometimes when I'm training my own team and I'm talking about like where you're touching people, why, like I really like the way you explained that, like about, because I talk about that too, and like hand placement, and you shouldn't be grabbing people and stuff like that. But I really liked how you explained it and kind of really tied into like your specialty, your functional manual specialty. How can people learn more about like your specialty that you've been spending the last 25 years,
Through, well, there's classes that will teach these principles, and they were founded by Greg and Vicki Johnson, and they're out of Colorado Springs, Steamboat Springs in Colorado. Okay. And their organization is called the Institute of Physical Art, and their courses are open to OTs as well as PTs. Especially, there are several courses that we're actually hosting a course here in like 3 weeks, and it's the upper trunk. So everything from upper trunk manual techniques and how to understand a paradigm of how to work on the mechanical, the neuromuscular, and the motor control issues in the same treatment and evaluation approach. And that's what helps with this, with me and my brain, because I can't think about, 1, 2, 3, 4. I was like, you know what? All I can do, I know that's not moving. I know to get it moving.
That's awesome. I like that, but simple is, sometimes the best. Now, I want to ask you real quick, is this I've seen certain manual certifications, right? The one that you're recommending, the one that you've done, is it a series of just classes that you can take over time, or is it like a certification program where you're taking it almost like within a year that gets you certain letters behind your name and stuff like that?
Right, and that's a good question. This certification is actual I think they may have changed it because they've expanded the course schedule. But when I took it, there's 8 courses you have to take. So if you're taking 1 2 year, that's going to at least be 4 years
Yeah,
plus.
no, it takes time to develop specialties,
Right.
it takes time to develop specialties. And I think that's what people need to realize. It's just not like a one-time wham, bam, thank you, ma'am type of course. Those courses can be great, like online courses can be great, or, very targeted specific courses can be great, but certifications take a lot longer.
Certifications that are worthwhile for sure.
Yeah. So, but it's like one of those things where you can take a series of courses over a period of time to get that specialty.
Right.
That's the one you did, right?
Yes.
Well,
So I studied for over 10 years to make sure I got it down.
yeah. No,
I knew this is the way I wanted to treat. So I wanted to,
yeah.
for myself, see if I've accomplished that level of competency and expertise in this, since I wanted to be, this is, again, I said, hey, I'm treating this way no matter what.
Yeah, no, for sure. And I think, when it comes to becoming a certified hand therapist, we tend to focus a ton more on post-surgical cases versus like non-surgical cases. Now, there's a lot that we do in non-surgical cases, but it's not very targeted specifically to to a particular technique, but more like the background, the biomechanics of how everything moves and how it affects each one of them, but so much about the certification to be specialized in hand therapy is about treating post-surgical and all the, versus like the non-surgical. But we do a ton of non-surgical here at my clinic too. And I think it's a great way for OTs to treat, because not everyone has surgery, not everyone needs surgery. And there's a ton of people with upper extremity, upper trunk, upper body types of issues that really need our specialty. And there's a lot of different things, just like what you said. And part of it's, you have your observational skills, but then you have your tactile skills, and then you have your communication skills.
I tell patients all the time, what we have to do is we have to enable them to move before we can expect them to move. You can't say, oh, your wrist is weak, let's do some exercises. But if they can't fully extend, they're not going to get the full benefits from those strengthening exercises.
No, for sure. Absolutely. Well, I really thank you. I'm going to include your links below. So anyone who's interested in finding out more about your clinic and the courses that you recommend to take, I'll include all of that in the links below. And I hope that in your area, you continue to support OTs and potentially even hire an OT one day in all of your clinics. You can totally expand into tons of surgical stuff too. I can talk to you about all of that. All right.
I enjoy. Thank you very much.
What were you going to say?
Said I always enjoy the camaraderie with other therapists, and this is where I feel like we could all help each other, understand more about getting our patients better faster.
Yeah, totally. I believe it.